Hi, everyone. Today, I'm going to be talking about calcium disorders and rickets. So this is the sixth video of this academic half-day um, video lecture series. So this is the last of these video series. So I'm going to be discussing about calcium with focusing on hypocalcemia, and at the end we'll be talking about some cases of rickets. And during the academic half day, we'll go through some case scenarios, which will allow you to have a better understanding of calcium disorders. So I understand many of you feel like it's a little complicated in terms of a pathology and hypocalcemic disorders. So today I'm going to be going over like the basic knowledge, which will help you when you see a case of hypocalcemia. So as you remember, there are 4 parathyroid glands at the back of the thyroid, right? And they are derived from 2 embryonic origin, right? The 3rd and the 4th pharyngeal arch. So this is the reason why parathyroid gland have such a high reserve, because there are 4 glands, right? So even if one gland is not working, the other 3 can compensate for, or even if 3 glands are not working, 1 gland can compensate for the other 3. So this is the reason why hypoparathyroid in general, it's found at much lower prevalence than other endocrine disorders. So let's review the calcium homeostasis. So when the calcium in the blood decreases, it stimulates the parathyroid to stimulate parathyroid hormone, right, or PTH. So what does PTH do? It has 3 major effects, right? So number 1 is on the bone. What does it do? PTH stimulate osteoclast, right, to resorb the bone, right, which then release the calcium into the bloodstream, right? So the first action on PTH is on the bone, stimulate bone resorption through osteoclast. Number 2, it's in the kidney. So what does it do? It actually increase calcium reabsorption, right? And also increase the excretion of phosphorus, which is called phosphaturia, right? So increase calcium reabsorption in the kidney, increase excretion of phosphorus, which is called phosphaturia, right? And the last place is in the GI tract, right? So in the GI tract, it increases calcium absorption through the GI tract, right? So this action is through the active vitamin D, which is calcitriol, okay? So when calcium in the bloodstream or in the serum increases, it actually has a negative feedback to the parathyroid, right? So the calcium itself can turn off the PTH secretion once the calcium level is back to normal, right? So it completes the feedback loop, right? So this is a little different than the other hormones in a sense that it's not involved hypothalamus or pituitary, right? So the calcium itself can provide a negative feedback to the parathyroid gland, right? So we talked about a action of PTH that increase calcium absorption from the GI tract, right? And it requires a active vitamin D, which is called calcitriol, right? So where is calcitriol produced? It's actually produced in the kidney, right? So remember, when the calcium drops, PTH is secreted, right? So it activated the conversion, right, from 25 hydroxy vitamin D to 125 dihydroxyvitamin D or calcitriol, right? It does so by the activation of the enzyme called 1-alpha hydroxylase, right? So it hydroxylates the vitamin D to become 1,25 dihydroxyvitamin D. This is the reason why patients with chronic kidney disease requires calcitriol, right? Because they cannot make the active vitamin D, right? And again, calcitriol has an effect in the GI tract to increase calcium absorption. Now, let's talk a little bit about vitamin D metabolism. It's also very important for you to understand. We need to go back to like the metabolism of vitamin D, right? So when we talked about vitamin D, it's either ergocalciferol or cholecalciferol, right? Both, you can bind it as a supplement, right? So that's in the market, there are both forms, ergocalciferol and cholecalciferol, right? And remember, our body can synthesize cholecalciferol, right? When we're exposed to UV light, the fat can be converted to cholecalciferol, right? So what happened to the vitamin D, right? It gets first metabolized in the liver, right? With 25 hydroxylase enzyme to become 25 hydroxyvitamin D. Now remember, when you order vitamin D level, we look at the level of 25 hydroxyvitamin D. Why? Because this is the most stable form of vitamin D, right? So calcitriol fluctuates, the level of plain vitamin D also fluctuates, but this level, 25 hydroxyvitamin D, is the most stable and is the best indicator of vitamin D storage. This is the reason why when we order vitamin D level, we use 25 hydroxyvitamin D, right? So 25 hydroxyvitamin D is metabolized in the kidney by 1-alpha hydroxylase and become 1,25 dihydroxyvitamin D. And this is the active form of vitamin D, right? Or we call it calcitriol, right? The other name of 25 hydroxyvitamin D is calcidiol, right? Because there are two hydroxyl group. When there are three hydroxyl group, it's called calcitriol. Okay, so this is the vitamin D metabolism. Now you have some basic understanding, right? PTH, calcium, and vitamin D. This also can be upregulated by the PTH, right? So in summary, PTH has three actions in the kidney, right? First is increased calcium reabsorption. Second is increased phosphorus excretion. And the third is to increase the production of 1,25 dihydroxyvitamin D through 1-alpha hydroxylase enzyme, right? I really want to emphasize this. When you see hypocalcemia, it does not necessarily mean that the patient has vitamin D deficiency. I always hear that all the time. When I get a consult, the first thing that we do is check vitamin D level. I would explain later that majority of patients with vitamin D deficiency do not have hypocalcemia unless it is very severe and it's prolonged. And the duration of vitamin D deficiency is prolonged. Okay, so otherwise, we don't usually see hypocalcemia in patients with vitamin D deficiency. Now, you would want to review the presentation and the symptoms of hypocalcemia. Very important, right? Because when we see a patient, these are the symptoms we should be able to obtain from the patients, right? In a newborn, often they present with jitteriness or some have convulsion, right, in a severe case. Now, childhood and adolescent, you might want to review what is Chauvet-Stech sign or Trousseau sign. Okay, so I'm going to be asking you about a Trousseau sign in the quiz. right? There is an old term of Trousseau sign, right? When it was first described, it was seen in one of the disease, right? So there is an old name of Trousseau sign. It's called Trousseau sign of latent da 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 da. So something that you could look it up, right? I'm going to be asking in the quiz, right? And also, when hypocalcemia is severe, you could see a patient who had seizure or you have loss of consciousness. So this is a reason why when you see patient with seizures, one of the things that you might want to check is their calcium level, right? Whether are they suffering from hypocalcemia or not. Okay, many of my patients with hypoparathyroid or pseudo hypoparathyroidism, the first signs that they went to the ER is seizure. Right. So, and the important finding is EKG change, right? So if you have an characteristic EKG change, such as prolonged QT interval or arrhythmia, that indicates that it's severe and the patient may require intensive care unit. The patient may require calcium infusion and monitoring, right? Because you can have fatal arrhythmia. So when we talked about hypoparathyroidism, I want you to know that most of the time you don't see a low PTH, right? You see a relatively low PTH for the level of serum calcium, which means that you can have a normal PTH, right, with hypocalcemia, but that's not normal for hypocalcemia, right? So when you have a hypocalcemia, PTH level should be elevated, right? So in hypoparathyroidism, when you have a low calcium, you also have elevated phosphorus, right? Remember, because you don't have phosphaturia effect of parathyroid. So you could see elevated phosphorus, right? You can also see a very inappropriately low 125 dihydroxyvitamin D. Okay, so this is a reason why when we were consulted on a hypocalcemia case, one of the first things we ask is to obtain PTH, right? Because you want to see a PTH level during the time that the patient has hypocalcemia. Okay, it changes very quickly. So when you treat the patient, when you infuse the calcium, usually the PTH will already change, right? So you might, you want to check when the calcium is low, right? So this is the reason why we say that if you see hypocalcemia, if you can obtain one blood test, we often ask for serum PTH, right? Because it helps us with the differential diagnosis, right? So is this hypoparathyroid or not? Okay, so so when we talked about the cause of hypoparathyroidism, right, you can be talking about somebody who has no parathyroid gland, right, which is one of the syndrome we know pretty well is DiGeorge, right? So DiGeorge syndrome comes up in the board very frequently. So you might want to review the DiGeorge syndrome, right? So again, another clue, I'm going to be asking you about a DiGeorge syndrome, right? So Dr. DiGeorge is an endocrinologist. He worked at St. Christopher Children's Hospital in Philadelphia, and he wrote a chapter on endocrinology in one of the most important pediatric textbooks. And you might want to check that out. Which textbooks is that? Okay, the first edition of that textbook, right? Or you can have a patient who has thyroidectomy and it was accidentally removed. Nowadays, we don't see that often because the thyroid surgeons are very careful, right? And they try to dissect, the anatomy without disturbing parathyroid gland. Okay. One of the etiologies of hypoparathyroidism is autoimmune polyglandular syndrome, or APS. right? It's one of the syndrome, right? So that you can have hypoparathyroid, right? There's also miscellaneous cause. Hypomagnesemia. Hypomagnesemia can actually cause a delay release of PTH, right? So when you see, in newborn infants, that have hypomagnesemia, they can also have a delay response in PTH, right? So that's one of the reasons why we always obtain serum magnesium when you see hypocalcemia as well. Okay. Now, iatrogenic, I included in because it's more like an iatrogenic cause of hypocalcemia. Okay. I would tell you the majority of our cases of hypocalcemia is caused by iatrogenic, right? So patients that are receiving TPN, right, or they're patient with dependent on G-tube feeding. Okay, so many of these are considered iatrogenic, right? So it's not hypocalcemia that's caused by PTH, right? So the PTH is often elevated, right? So what is DiGeorge syndrome, right? So it is actually a contiguous gene deletion syndrome, right? Contiguous gene deletion mean that you have a very large, large deletion of a region that encompasses many genes, right? And you have several phenotypes related to all the genes that are deleted, right? So the deletion is in 22q11.2, right? So 22q11, right? So it's part of a big spectrum that we call 22q deletion syndrome because there are many important genes in that region, right? So it's important for a embryogenesis of many structures that are derived from pharyngeal third and fourth arch, right? So what are these organs, right? Parathyroid, thymus, heart, right? Major vessels, velo-palatine muscle, and facial anomalies, right? So the heart conditions in DiGeorge syndrome, now we found that there are many, many different types, ranging from just simple VSD or to like conotruncal anomalies. So the heart defects in DiGeorge varies. Okay, this is the picture of a patient with DiGeorge syndrome. I would have to admit that the first time I saw it, it looks very subtle, right? Its kid doesn't look like a major dysmorphic, right? But we could see that the patient has a very small mouth, right? It's like a cupid bow lip, upper lips, right? And has some wide, a thalacanthus, right? And some low set ears, right? So this is a facial anomalies seen in patient with DiGeorge syndrome. Okay, so there is also another cause of hypocalcemia that is very confusing to many residents. It showed up sometimes it shows up on the board exam, not very often. I was going to cut it out, but then I saw a question or two on pseudo-hypoparathyroidism, so I decided to include it, right? So just to kind of give you like some introduction so you understand what it is, right? So what this is a structure of the PTH receptor, right? So what is it? It's a G protein couple receptor, right? So it coupled with a G protein, right? And the alpha subunit is called GS alpha or GNAS. Sounds familiar, right? So it's the same gene that caused McCune-Albright, right? So name sounds familiar because Dr. Albright just described all of these syndromes, right? So, but this is Albright hereditary osteodystrophy, right? It's a different syndrome. Excuse me. So what happened? So you have a inactivating mutation of a GNAS, right? It causes a excuse me, it causes the receptor, the G protein to become inactive to the activation by PTH, right? So it's the opposite of McCune-Albright, right? So the pseudo-hypoparathyroidism, right? So what happens? You have a hypocalcemia, right? You get hyperphosphatemia. It looks like hypopara, but you actually have an elevated PTH level, right? And there's a distinct characteristics, right, of a type 1A. There are 5 types of pseudohypoparathyroidism, but the one that comes up on pediatric board is type 1A, right, which is called Albright hereditary osteodystrophy, right? So you have a patient that are usually have short stature, they're obese, they have short stubby hand, and they have short fourth metacarpal bone, right? So one of the distinct feature is a short fourth metacarpal or metatarsal bone, right? But when you talked about biochemical findings, it's identical to hypoparathyroidism except for elevated PTH. Okay, so another category is hypocalcemia seen in newborn. Many of you who have rotated to NICU or nursery have already had patients with hypocalcemia, right? So it's a very common problem in newborn. And what we know is that there are you could divide it in 2 types, right? So one that happened very, very early, right? Within the first 72 hours. It's usually caused by other problem than PTH, real PTH problem, right? It's caused by perinatal stress, like SGA, hypoxia, right? Or infant of maternal with hyperparathyroidism, right? Why? Because similar to infant of a diabetic mother, right? So the mother have very high calcium level, and the calcium level suppress PTH release in the newborn, right? So you have actually a very delayed PTH response to calcium, right? So it's a very common problem in preterm infants or infants with perinatal stress, right? The late phase, or the one that persistent, these are the one that actually are more suggestive of a real calcium disorder, okay? Now, let's talk about rickets, right? And this is another area that many are still confused, right? So what is rickets? It's actually a defect in mineralization that involves growth plate. Remember, it's a mineralization defect, right? And it involves a growth plate, right? Which cause characteristic changes on radiogram, right? Now in adult, we call it osteomalacia, right? But in adults, growth plates are already closed. So you don't see rachitic changes on the growth plate, right, in adults. And I want to emphasize again, not all rickets are caused by vitamin D deficiency, right? So yes, for the board, it's very important to review vitamin D deficiency rickets, but I want you to know there are more than just vitamin D deficiency. Okay, so these are the rachitic changes we talked about, right? So you see the cupping and fraying of distal metaphysis, right? So the place we usually see is on the wrists and in the knees. So what happened, right? So why do I say that vitamin D deficiency does not always result in hypocalcemia, right? So what happened in a patient with vitamin D deficiency, right? So you have a decreased calcium absorption from GI tract, right? So what happened? Calcium goes down. It is compensated by an increase in PTH level, right? And if you can take enough calcium, right, this can be compensated for a decline in calcium absorption. So this is the reason why you don't see hypocalcemia in vitamin D deficiency that often, because it can be compensated by PTH and also with the active absorption in the GI tract, right? But what happened, right? So if you have a very prolonged period of vitamin D deficiency, the high PTH will start to rise, and it will cause increase in phosphaturia, right? Remember, PTH causes phosphaturia, right? So it can cause hypophosphatemia, right? PTH, remember we talked about calcitriol, right? So calcitriol also is important for phosphorus absorption, right? So it's a combination of both low calcitriol and high PTH that results in hypophosphatemia. So what happened after that? Eventually, you cannot compensate for this decline in calcium absorption, right? So you eventually would have hypocalcemia, right? Until that time, that you would only until then you get a rachitic changes, right? So it has to be prolonged, it has to be severe, right? So who's the most susceptible to vitamin D deficiency rickets? Infants who are exclusively breastfed, right? Because not only breast milk has low vitamin D content, it also doesn't provide, it provide less amount of calcium, right? I know we always promote breast milk and breast milk. This is probably the only area that exclusively breastfeeding it can cause a vitamin D deficiency. This is a reason why American Academy of Pediatric recommends vitamin D supplement in infants who is exclusively breastfed, right? Remember, like this is a #1 recommendation, right? Infants that are exclusively breastfed needs to have vitamin D supplementation, right? So in my first job after fellowship in Ohio, I've seen a few of infants who present, or infant and toddlers who present with vitamin D deficiency rickets due to an exclusive breastfed without vitamin D supplement. Okay, so this is just a diagram that I drew just to show you, you know, the changes that we talked about, right? So the black line is calcium, right? So when you have a vitamin D deficiency, right, the calcium starts to drop, right? This is the duration of vitamin D deficiency, right? The pink line is PTH, right? So what happened to PTH? PTH starts to rise, right? So to maintain the calcium level, right? The rise in PTH caused a drop in phosphorus, right? Through phosphaturia, right? So this is the first phase, right? So when you do the blood test, you'll see a relatively normal calcium, right? You may start to see a rising in PTH level, right? So what happened if it's prolonged, right? So PTH continues to rise, right? So it's causing a further decline in serum phosphorus, right? And when it reaches this phase, right, when you know you cannot compensate it anymore, serum calcium drops, right? So eventually you get hypocalcemia, hypophosphatemia, and you get rachitic changes, right? You see the difference between hypoparathyroid that cause hypocalcemia and vitamin D deficiency that cause hypocalcemia, right? So in vitamin D deficiency, you always have low phosphorus, right? Unlike hypoparathyroidism that you see hypocalcemia with hyperphosphatemia, right? So this is a major distinguished feature between the two conditions, right? So if you have a chance, when you get calcium, also get phosphorus, right? So it does help excluding or including certain conditions. Right. So again, all types of rickets has hypophosphatemia, right? It doesn't matter what it is, you must have low phosphorus before you start seeing rickets, right? Hypocalcemia alone does not cause rickets, right? We saw that in hypoparathyroid patient, they do not develop rickets, right? Because they have high to normal phosphorus level, right? Now, there are different types of rickets, right? There are two types that you want to review for the board exam: vitamin D deficiency rickets and hypophosphatemic rickets. So I mentioned in the previous slides, right? So vitamin D deficiency rickets is caused by severe and long-standing vitamin D deficient, right? Especially in those infants who are exclusively breastfed. You see an elevated alkaline phosphatase, right? It's a marker of bone activity, right? You see rachitic changes on the X-ray, and you see a characteristics finding of low calcium, low phosphorus, and very elevated PTH, right? Now, when we talk about hypophosphatemic rickets, is different than vitamin D deficiency rickets, right? From the X-ray, you cannot tell whether this is vitamin D deficiency rickets or hypophosphatemic rickets, right? Unless it's a very, very long-standing case, because in hypophosphatemic rickets, you start to see other bone abnormalities, right? So what is the pathology of hypophosphatemic rickets? It's a phosphate wasting disorder, right, through the kidneys, right? For some reason, the kidney cannot reabsorb phosphorus, right? So what happened, right? When you get hypophosphatemia, you see an elevated alkaline phosphatase, right? You have low phosphorus, but you have relatively normal calcium and PTH. Remember, if you don't see the change in calcium, PTH usually remains normal, right? So this is one of a distinguishing biochemical features between vitamin D deficiency rickets and hypophosphatemic rickets, right? So hypophosphatemic rickets has normal calcium and PTH. Okay, now hypophosphatemic rickets have all three modes of inheritance, right? It could be autosomal dominant, autosomal recessive, or X-linked, right? So I'm going to be asking you during the quiz, right? The most common form is X-linked, right? So we call it X-linked hypophosphatemic rickets, the most common form of hypophosphatemic rickets, right? So when I took the board exam, one of the questions that I remember until today, they asked about the mode of inheritance of hypophosphatemic rickets, right? The answer is all three: autosomal dominant, autosomal recessive, and X-linked. They have all three forms, right? However, if they show a pedigree, right, that only the mother passed it to the boys, right? So it's X-linked, right? So look at the pedigree, right? I've seen both questions. All right. So I think we cover pretty much everything in the calcium and rickets, enough to go through our academic half day, right? So we're going to be talking about the cases during academic half day and the quiz.